With this, I would like to request Dr. Ashok Seth, Chairman, Fortis Escorts Heart Institute, to come and give a special address. A huge round of applause for him, please.
Good morning, dignitaries on the dais, friends, colleagues, ladies and gentlemen. This is a very important forum, and we always talk about such forums as benefiting everyone who attends it, and perhaps benefiting the nation at large. And I would say that all this revolves around what we wanted to do, create a forum all the time, not just in this room, but all the time at every place where we sit and have to think of healthcare delivery, to talk about the stakeholders getting together, the industry, the academia, the healthcare professionals, the regulators, and the government. And unless we all sit together, we never define the path ahead. Now, you know that for the last 30 years of defining the path of interventional cardiology in this country, I've also defined the path for healthcare delivery in this country. And perhaps that's one of the instances one of the reasons why I stand on this podium today. And the definition of path has been in terms of innovation. And perhaps some of you expect me to talk about numerous innovative practices in therapy of interventional cardiology that I've introduced over the last 30 years. Some of you may have read the most recent of the innovations that we created in partnership with the industry, and many of you know that. The stents, the metallic stents used for the treatment of coronary artery disease, had transformed over a period of research, of which I was an integral part across the world, by a Western company into an absorbable stent. The stents which are put into the arteries of the heart to treat blockages became absorbable, became plastic, and would disappear over a period of 2 to 3 years and leave nothing behind. A transformational technology for the treatment of most dreadful disease of the world. And yet, because they were thick, they were crude, they were the first generation, and yet with a $2 billion investment created by one of the biggest companies of the world, they didn't stand the complete test of time. To the extent that what was needed was a thinner strut device to go into the coronary arteries. Thinner stents, thinner scaffolds, thinner bioresorbable stents. And that could not be created by them after 2 billion research, and was created then by an Indian company. Now that is fascinating that an Indian R&D created the world's first thinnest bioresorbable stent, which in partnership we actually put into trials in this country through permissions from the Drug Controller of India. And lo and behold, it stood the test of the trial. It was presented at the biggest meetings of the world, published in the biggest peer-reviewed journal, and has become a reality for the first thinnest bioresorbable scaffold in the world. The rest of the world then took the same path of trying to create a thin resorbable stent, but India took the lead in that. We talk about valves, replacing valves without surgery. And of course, while we were integral part of the first in human studies for the first non-surgical, catheter-based, in the cath lab change of a valve, which is phenomenal. Patient walks home the next day after having a valve replaced without surgery. You would read more about that in the ELITS magazine, but that's become a reality. In 2004, we did the world's first case. It was transformational. We were a part of the first in human study. That technique took on so successfully that by this time 150,000 implants are getting done across the world, and it has become the treatment of choice for all patients above the age of 70 who have the aortic stenosis or the blockage of one of the valves in the arteries. And yet, the Western valves now cost us $35,000. And in the last 3 years, we developed an Indian valve to be inserted through the groin. Again, through the permission of Drug Control of India, it's evolved into trials. The trials at 1 year proved the data to be successful. A month ago, it was approved by the Drug Control of India for commercial use in this country. And we hope that that $35,000 figure goes to half that price, because these are innovations in practice. But I'm not going to dwell upon these. I want to talk something more different. I want to give my philosophy to you all about where do we go from there. You see, I talked about 2 or 3, and you'll read about this in the edicts. But all we're aiming for is a much bigger issue. Availability, accessibility, affordability has been understood by everybody. But how do we actually get there is the real. We talk about innovations, and I talked about two innovations. But if $35,000 was the cost of that valve, and it comes down to $17,000, it's still non-affordable, should we say. How do we really get it affordable? And there's a lot of it that I'm going to talk to you, but let me just do that in the 10 minutes that I have. And I guess I'm transgressing on the Mr. Dinesh's time. So I hope that you don't mind that we can actually extend my talk a bit. That when we talk about cost-effective solutions, and all of you, the industry here, have to consider cost-effective solutions. We're talking about frugal innovations. Frugal innovations may mean jugaad at some stages. After all, it's a continuum of a process. So we may be able to do a jugaad by copying something from the West and creating it just at a lower cost by a copyright infringement, or maybe there was no copyright, and we created something which looks similar and actually can get done. So we call that frugal innovation. We call that jugaad, and it's very important. But if really R&D has to go into these frugal innovations, which have a huge widespread implication, then there is a cost involved in it. And I want you to all understand that local R&D becomes an integral part of any form of innovation. We have to actually create stuff which is for the Indians, made in India, and at a cost which the Indians can afford. And I know that none of us is in the business of philanthropy in creating this, whether the apps are getting created for provision of healthcare delivery at home, whether the apps are getting created for a patient to meet a doctor, whether an app is getting created for an ECG to be diagnosed at home, at the end of the day is some pot of gold at the end of the rainbow, which the innovator is looking at, because there's a lot gone into R&D. And therefore, a milieu has to be set up where R&D, where innovation does get a reward. So that's the first context that we need to dwell on. How do we actually reward innovation in a positive manner without believing that it should be done as a philanthropy? And that requires, again, a partnership of all stakeholders to start understanding that. But frugal innovations cannot be at a cost of quality. And the second point I want to make is that quality outcomes becomes the measure of frugal innovations. Cheap should not translate into substandard. How do we actually achieve that? Is our final answer. So we may be able to lower the cost of healthcare through numerous schemes, but unless the patient gets better and doesn't come back into the hospital after that treatment, if it got provided at a cost of 50,000 rupees, was not the issue. The issue is not that he had what was earlier at 2 lakh rupees at 50,000 rupees. The issue is, did he have the same quality of treatment at 50,000 rupees that as 2 lakh rupees? And if we can get that, if we actually can measure that, we would be the winners. And that's what the West does. The West doesn't look, the West reimburses cost, but then looks at how many times the patient came back for readmission after that. And those who came for readmission after a therapy are not paid subsequently, because that was inadequate and low quality care. The third aspect is that we talk about developing an ecosystem for promoting research and development. And I think that's very important, and perhaps days, sessions like this may influence some of the policy makers, in fact influence all stakeholders to start thinking about how strong the public-private partnership can come in to encourage the ecosystem of innovative therapies. We have to improve our infrastructure, irrespective of any innovations we create. And I want you to think through that. We create innovations of low-cost ECG machines, apps which do ECGs at doorstep. But what is the point of diagnosing an acute MI out there in the village if he can't even have therapy, if his first therapy for that heart attack lay 35 miles away? It doesn't make sense. So innovations and healthcare delivery have to improve simultaneously, side by side. We have to provide infrastructures. We might be able to overcome, through innovations, the lack of some of the expert personnel. We talk about no doctors available. Our apps can actually make a patient in a village on artificial intelligence measure his blood sugar and even adjust his medication based on blood sugar levels. He can measure his blood pressure and adjust his own dosing based on blood pressure measurements through apps and algorithms created by artificial intelligence. We can move forward and replace some of the infrastructure that we don't possess. But for anything beyond that, we would actually need infrastructure to be able to help people. I always say this. We talk about free camps, and I have encouraged free camps. Going out, doctors going out, seeing hundreds of patients, diagnosing illnesses. But what's the point of taking an echo machine to a village and diagnosing that the patient has severe heart disease, and you're telling the patient, come to our hospital, it'll cost you X. Go to a government hospital, you'll stand there for the next 1.5 years not getting the treatment. So the patient is diagnosed and somehow left to die. That is the irony of what we face in our daily lives. How do we actually correct that? Well, we correct it by having an infrastructure where we diagnose for free and then actually treat at a highly subsidized or free rate. I think improving affordability has become a huge partnership innovation. I think the biggest innovation in this country by any means clearly has been the Ayushman Bharat. I say this with great confidence. Imagine the innovation which has gone into Ayushman Bharat. We talked about, I just gave you an example of how if I diagnosed a heart attack out in the periphery through an app, and I said, go, you're having a heart attack. And what does the patient stay and look at me? What does that mean? What do I do? And I say, you just drive for 50 miles, you'll get to a place which will do it. It's no more there. A person walking on the street anywhere can now actually have a therapy. Imagine the innovation around the 1.2 billion people, half of the country of 1.2 billion people actually having an affordability issue, availability, accessibility. We're actually achieving a lot through this Ayushman Bharat. Now there have been numerous critiques around Ayushman Bharat, and I always brush off those critiques by a simple fact of saying that firstly you saw a will. I, as a healthcare provider, could never see how to take care of 1.2 billion people. You saw a will, you saw creation, you saw also an execution of it started. Now that is huge. Any critique, any project we know doesn't even get to this stage of an execution in the short time that it has been innovated. And it can only be a process of time when this would be perfected. And in a few years, this would be the biggest creation ever across the world to deliver the highest quality of healthcare. All these figures of costs that you see, reimbursements that you see, the complaints about reimbursement are real. I agree with those. But they're going to be tweaked over a period of time. Nothing is written, engraved in stone. They're going to be realized over a period of time. The quality parameters that I talked about are going to be inbuilt into this Ayushman Bharat. Soon after I'm sure that in a year or two, what Ayushman would be looking at is not just reimbursements. We're looking at, did our patients do better? Did our patients do fine? Did they not get readmission? Were they given a stent which actually made them free of disease process for the next year, for the next year and a half? Was the quality of the stents good enough? Made in India, to actually give the best outcomes to our patient. And those who gave the best outcomes would actually be reimbursed better than the ones who did not give it. So I believe that we are working towards, with a positivity, towards a better India, towards a healthier India, and I think it's time for us, all of us, to work passionately together to create a healthier India, because a healthier India can only be a better India. Thank you very much.